So our first speaker, Associate Professor Hannah Moore, who's going to be talking about Australian RSV infection rates, post-COVID-19 review in infants and older adults, and of course Hannah is the theme head of infectious diseases at the Kids Research Institute of Australia, and the full bio is available both in the thing you've got there and on the Immunisation Coalition. So I'd like to invite Hannah to the stage. Thank you very much, and sorry for cutting your entree short.
Thanks very much, Paul. Matt Brymundi is yummy. Okay, thanks very much for inviting me to talk here today. And I think for anyone who attended any of the RSV sessions today in the conference, this talk is really, we're going to fly through this. It's mostly stuff that we generally know to set the scene on RSV infection rates. Post-COVID's in brackets because I am going to cheat. I'm going to do a little bit of pre-COVID data as well, because I think that's important to sort of set the scene for what we're talking about. So I'm going to give a little bit of just a very broad context of RSV burden in Australia, and then focus really on infants and then adults. And then for both those groups, I'll talk a little bit about the current trends, a little bit about variable testing and under-ascertainment, some of the issues that we see, some current trends using our current data, and then for adults, really talk about some of the data gaps, which I think is a really important bit. So I think most people are familiar with the burden of disease pyramid and how we like to capture what the burden of RSV disease is. Fortunately, in Australia, deaths, especially for children, are quite rare. There's a few deaths in adults, but I think that's a little bit under-ascertained as well. But generally, our deaths for RSV in Australia are quite rare. However, our hospitalisations are certainly not rare. We have a very large burden of hospitalisations for RSV, both in young infants and in adults. And we know that in those under the age of 6 months, hospitalisation rates can be up to about 1 in 30 children can be hospitalised for RSV. We know RSV hospitalisation rates are about 8 times greater than what they are for influenza. But the problem with RSV, as we know, is that it relies a lot on diagnostic coding, and we know that diagnostic coding is not perfect, and so we have variable testing, and I'll get into some of that, what that means. We have a significant adult burden, but I think that's grossly underestimated, and I'll touch on that briefly. Community burden for RSV, I think, is largely unknown. We need to do some further work to really understand that community burden. And as far as I'm aware, we think asymptomatic detection is rare. Maybe in children it's rare, perhaps maybe not so much in adults, but that's something we need to do a little bit more on. Okay, so let's start off with infants and children. Let's start off with what we do know. So I think we all are familiar with this paper, Gemma Saravanos' paper in Medical Journal of Australia, really set the scene for RSV rates across Australia. So you can see that the rates in young children are actually quite high. However, this is RSV coded data, so this is ICD codes, and we know that there is a bit of an under-ascertainment with that. When we look at ICD codes, you're only really seeing that tip of the iceberg, so that's only what we can really see. What is hidden then underneath the waterline is this very big, large hidden burden of disease. So that under-ascertainment from variable testing, because we know that these ICD codes are not very specific. So this was a study that we did in Western Australia, where we had the opportunity to link laboratory data, which had test negatives as well as test positives, so we could really understand that testing pattern for RSV. And then we developed up a statistical prediction model, which then better calculated what the true burden of RSV would be in that counterfactual scenario if all hospitalisations were actually tested. And what we found in that graph is that for some of the younger age groups, we're really under-ascertaining RSV, potentially by up to 50% in some of these younger age groups. More recent work using this testing model, again in Western Australia, has shown that we have variation of these testing patterns in different geographical regions as well. So that means we have variable under-ascertainment across different geographical regions. And really, I know there's a lot of information on this slide, But really, if you focus in on that last column there, which is that under-ascertainment burden, if we combine just looking at laboratory-confirmed RSV to the RSV that would be laboratory-confirmed, or the true cases that we get from this prediction model, so in the hypothetical situation that all hospitalisations are tested for RSV, you get to see there's actually quite a large discrepancy there, and in some of the rural and regional areas of our country, we're really under-ascertaining what the rates are for RSV. I think to really put it into context, we need to understand the epidemiology and the risk factors for RSV as well. So I'm double dutching here. This was a slide from a presentation that was earlier today. This is courtesy of Minda Sana, a postdoc in my group. And it shows that the risk factors for RSV in those under the age of 12 months on the left-hand panel, and then it shows the population attributable fraction of these factors on the right-hand panel. So that's when you look at these risk factors, but then you put them into context of the population. So it takes into account how prevalent those risk factors are. So while we know that there's lots of really important risk factors, extreme prematurity, medical conditions, there's actually other factors that actually contribute more to the population attributable fraction. And these are some things like being born in autumn or winter, or being born to a family that already has a couple of kids in the family. So it's that really presence of siblings. So I just think it's really, really important for us to understand the context of the epidemiology of RSV that we're trying to prevent. So, yes, you can see that. Sorry, I forgot to put those on. So really focusing on preterm birth and the medical conditions for the risk factors. And then when we look at the paths, you can really see it's those that are born in winter and summer, or those that have multiple children in the family. So to tease this out, this season of birth a little bit more, this is unpublished data from our data linkage set. Again, sorry, it's Western Australian data. So these are our age-specific RSV hospitalisation rates. It's a pretty curve that we've generally known. So you get this peak of admissions in the first sort of 3 months of life, and then it starts to decline. Doesn't disappear, but it does sort of start to decline. This is for all births. Now, if we actually look at it by season of birth, so pulling out those that are born in summer, autumn, winter, or spring, you can see the blue and the green lines. They're the ones born in winter and in autumn and winter, where we know they have a really high rate of RSV, particularly in those first sort of couple of months. But if you just focus, I'm not sure if I have a pointer here, but if you focus on that orange line, that red line, that's those that are born in summer. So those babies that are born in the summer months, they generally have the highest RSV rates when they're about 6 or 7 or 8 months of age, which coincides more with the season of RSV, the seasonality as opposed to the age. So what implications does this have for our immunisation policy? If we have a maternal vaccine, it gives protection for the first 5-6 months of life. That's great for those autumn and the winter-born babies to offer the best protection. But those summer-born babies, they're going to miss out on that best level of protection. So potentially we need to think about the best strategy here, and maybe having a monoclonal antibody that's actually given for summer-born babies at the age of 2 or 3 months. That would actually get them over that next 6 months and get them over that large peak that they experience of RSV hospitalisation rates. So I think it just really makes us think about what do we need to do to have the best policy to protect the main parts of and reduce those hospitalisations. Seasonality is also not consistent across Australia. So on the little insert here on the right-hand side is data I pulled from the New South Wales Respiratory Surveillance Report. And then the data on the left-hand side is actually a slide I grabbed from Marette Dean, who's an MAE scholar who will be presenting on Thursday, session 6A. So just looking at the right-hand side, this is the current seasonal trend. So you can see that really on the east coast of Australia, RSV peaks around April or May. But when you look at Western Australia and just look at the southern Western Australia, so the rest of WA, that right-hand side one there, you can see the peaks of RSV are more like July and August. So the seasonality is not uniform across Australia, even in those that experience the same climate. And then if you look at those regions of Australia that experience different climates, and I'm sorry, I just do have Western Australian data here, but I suspect it's similar for Northern Territory and for Queensland that have more tropical and subtropical climates, you can see the seasonality is different as well, not clear seasonality, and it does stick around. Again, this really does have implications for understanding RSV epidemiology and understanding how we want to prevent it. So some of the current trends that we can see, this is all very much post-COVID data. So it's great now that we have all these Power BI dashboards, which allow you to interrogate data really recent, real time. So this was data that I pulled off at the end of May. This is from the PEDS network, so Paediatric Respiratory Hospitalisations for RSV across Australia. And you can see that we still have lots of hospitalisations in the under 6 months. That's really the important age group. You can see from 2024 to 2025, from April, the first blue bar there to the last blue bar there, it is a reduction. So we have seen less paediatric admissions for RSV in April of 2025 than what we did in April 2024. But I'm going to caveat that by saying that I don't think RSV has really kicked off yet in Western Australia and maybe not in South Australia either. So we just need to be able to understand these data and have a look at them a little bit more. We also have availability of these new reports. So this is a snapshot of the interim ACDC Australian Respiratory Surveillance Report. And this respiratory surveillance report now has data on hospitalisations, on some community burdens, some ED and notifications. So it's a really another useful way we can actually look at all of these data. But I think it's really important taking everything that I've just said into account in terms of testing trends and understanding different epidemiology by age, by season of birth, all these different risk factors. So it's important to look at all of these data into context. Okay, so now let's switch and let's go to adults. So again, starting off with what we do know. So again, back to Gemma's paper, the rates of RSV coded, they look pretty low to me. But I don't think any of us believe that that's what the rates actually are. So this is, again, RSV coded information, and one of the great papers to really show all of the RSV epidemiology across Australia, but quite low rates in adults. We do know there's significant under-ascertainment of RSV hospitalisation in these older age groups. This was a modelling study that was done by Alan Nazero in New South Wales, a PhD student with David Muscatello's group and Tony Newell's group. This was using all of Australian data from the AIHW, and we looked at coded estimates of RSV in comparison to flu, and then also did some time series modelling, so using a proxy measure of RSV in younger children as a proxy measure, and then did these time series models to calculate what that excess respiratory hospitalisation rate would be due to RSV. And if you just focus in on this one, this is the over 75s, and you can see that that modelled rate of RSV hospitalisation in those over 75s was about 8 times higher than what it was for the RSV coded rate. So significant under-ascertainment of RSV hospitalisations. A more recent example, again, from WA, this is from one of our PhD students who's just finished now and passed, David Foley. This is using our PathWest data, so our macro data from Western Australia, and it really shows the influence of testing and how changes in testing, especially for adults, can really change the story of what we want to look at. So I'm really struggling to see that. My eyes are getting worse. But hopefully you can see those numbers from up here. So you can see in 2017, the number of tests that were done for RSV is about 9,500. 2023, the number of tests that were done for RSV was 49, almost 50,000. So that really shows the influence of the COVID era and just how much more increases in testing that we're actually doing now. Now, what's interesting is that throughout these years, in the seasonal period, the percent positivity of these tests remained about the same. They do change a little bit over the whole year, but also remember these years, 2020, 2021, we had really unusual seasonality of RSV, with basically no RSV for the majority of 2020, then these massive spikes at the end of 2020 and into 2021. So it's just really, really important to understand the influence of testing, and is this an epidemic of testing, or is this true increases in disease in adults? When we look at these RSV detection rates, so we look at this in context of the whole population, again, you can see rates are so much higher in those and they're over 75-year-olds, and they're quite considerable in those over 60 as well. Again, comparing 2017, you have rates of 31 per 100,000 population, or 62 per 100,000 population, up to then 77 per 100,000, and then for the over 75s, 200 per 100,000. So this, to me, is the influence both of increases in testing, but I think it's also an increase in disease as well. But it's really hard to delineate those two, and we really do need to have an understanding of testing practices. This is also only public pathology data. Also in the era of COVID, especially for adults, the increase in the private laboratory testing sector has really increased as well. So we're really only seeing half the picture here. So again, really underestimating the rates. So these are some of the current trends across Australia for RSV notifications. So I pulled this data from the NNDSS. So these are notifications, so not just hospitalisations, but all notifications. And I just took the last couple of years of when RSV notifications became available and looked at it by these different age groups. So you can see a bit of a general increase over the age spectrum. So it's really those over 85s at the end here, but really over that 70 is really starting to get these really, really high rates. And you can see there's a bit of variation across the years as well. Again, I think this is influence of testing. We're getting better at recognising RSV. We're getting better at testing for RSV. That's going to make rates get bigger as well. So we really need to put all of this into context. So I really believe that we have significant data gaps in understanding adult RSV, and that is really hindering prevention measures, I believe, in terms of getting them into public policy. So some of the Australian specific gaps that I think we have is really RSV hospitalisations in those under 60. I think that's a really important group that we need to look at, and especially those with comorbidities. We don't have a good handle on adult data of those with comorbidities on a population level. The proportion of pneumonia or respiratory infection ICD codes that are attributable to RSV in older adults is a piece of work I think we need to do a lot more on. There's some international studies. There's a UK study that has tried to quantify some of this, and that'll be a little bit in Moret's presentation on Thursday. But I think what we need to be doing across Australia in jurisdictions where we can is do some more laboratory linkage. We really need to repeat all those prediction models that we've been able to do for infants, repeat that for the adult age group, because we really need to have a better understanding of what that under-ascertainment burden is and what the attributable fraction of pneumonia is to RSV in adults. And to do that, we really must include private laboratories as well. Okay, so in summary, RSV hospitalisation rates, as we know, highest in those under the age of 6 months, but RSV does not disappear after 6 months, so we need to think about prevention of RSV beyond 6 months as well. We need to account for variable testing to capture that under-ascertainment in all age groups, really, but significantly for adults. We really do need to understand risk factors and epidemiological characteristics, and they need to be considered so we can design the most optimal RSV prevention program. And I also think we're doing a lot in, maybe it's just my area, but we're doing a lot to increase awareness of RSV in infants, but I think we need to do a lot to increase awareness of RSV in older adults as well. I'm speaking from personal experience with my elderly parents. They've never really heard of RSV other than their daughter talking about it from work, but they know about pneumonia and they're scared about pneumonia, but they're not scared about RSV. So we really do need to bridge that gap. Finally, just want to acknowledge my team back in Perth and all of the data services that has allowed me to look at some of this data in Western Australia, and of course all their publicly available data that's available across the country now. We really do need to start using these a little bit more. But I also just want to acknowledge that we really do need to not think about just data, but think about the families. And I think I'm saying this as an epidemiologist. I think as epidemiologists looking at population-based data, we can get lost in just looking at numbers and data. But we need to remember that there's families around all of this, and all of these babies are all, their parents are all part of our RSV community reference group. They've shared these photos, they've shared their stories with us, and that's what we're trying to prevent. So I'll leave it there. Thank you very much.
Thanks very much. Yeah, not off the hook yet. We've got some great questions coming through. So what a powerful way to finish an amazing talk. So thanks very much for that. Remember to use the microphones. We've got time for some questions. So if anyone in the room has questions, please make your way to a microphone. We've got a couple of online questions to get started with. So why aren't some GPs wanting to test like PCR, as this inhibits true data results and knowing what is in the community? I had a recent flu-like illness and my GP said no testing. Why is that?
So I'm answering this as an epidemiologist, not as a clinician, just so we all are aware of that. I do think that because there's no good treatment options for RSV, that if you are guessing someone has RSV, why would you bother testing for it? Because it's going to tell you something that you already know. But what's really interesting when we speak to our community reference group and our mums, this is definitely of the younger children, not so much the adults, but the mums want to know. They want to know what their baby has got. So I think, it's an interesting question, and I think, the whole era of over-testing and, wastage of testing and things like that, if it's not going to change the clinical outcome of that particular person, then I can understand why GPs are a bit reluctant to test.
And a text question from someone in the room. So with RSV testing, are rapid antigen tests distorting reported rates of disease, and how should we deal with that?
So someone who's more brainy than me might have the correct answer for this, but as far as I'm aware, the rapid antigen tests don't make it into notifiable data sets anyway. So even though you might have more knowledge of a rapid antigen test that you can buy from the chemist, I don't think they're that great anyway, but don't quote me on that one. They're not going to make it into the notifiable infection disease databases anyway. So the hospitalisation data that I presented is very much within hospital testing. It's not by rapid antigen, it'll be by PCR.
So do you think that's something we should look at changing, still reporting those rapid antigen test results somehow, like we did with COVID for a little while at least?
I think there's a concern about that. You might get some decent data, some good sort of community trends, but you also might get some bad data as well. And I think with that, you're going to detect more of the milder cases as well as the more severe cases. So you're actually going to see increases in RSV, and the preventive products that we have now really are to prevent the severe RSV. So I'd be concerned that if we start seeing more of RSV detected by rats, you're going to see a massive increase, and we're not going to see a decrease from the immunisation products, and then there'll be an argument of the immunisation products aren't working. So we don't want to get into that world.
I think Luke might have been first, or Peter, I'm not sure. Oh.
Hannah. Hannah.
Yes.
Given that private labs get Medicare funding for the tests that they do you think they should be all required to report not only the positive tests but also those that they've tested and are negative, so we can get a denominator of testing and understand the differences in trends?
Absolutely. What a brilliant question. Absolutely. Of course they should, Peter. As we've discussed before. And I think, the beauty of how we've been able to do these studies in Western Australia is because the PathWest data gives you that denominator. So you have the test positives and the test negatives, so you can work out a model for test positivity. So without having that denominator for private labs, it's really, really hard. So absolutely, private labs should be encouraged to report negative testing.
Luke Spence from the Mater Hospital in Brisbane and UQ. Following on a little bit from that, I just got off the phone from Mark Butler, and he was really impressed by a lot of the data that you've presented here, and there seems to be a bit of a theme of data linkage. Now, he's found a couple of $1 million spare, and would like you to put together a group to, I suppose, come up with some recommendations for what we can do in the rest of the country. Because I know in Queensland, data linkage appears to be a bad phrase, particularly for the government. They're worried about privacy and things like that. Can you give us some insight on maybe what you do?
Sure. I think, let's just say I'm from a state that has championed data linkage for 35 years. We're actually about to have a 35-year anniversary of celebration of data linkage across Western Australia. That started with some fantastic people like Mark Dobbs and Fiona Stanley, and so we've built that data linkage infrastructure on decades of trust. We've never had a breach in privacy, which I think is really important. We are in the world of new data linkage systems, and actually I'm speaking a bit frustratingly here that we have multiple systems now. We don't need to have multiple systems, we just need to have one good system. So there's the ABS PLIDA system, which is fantastic, has a big wealth of data, doesn't have hospitalisations, doesn't have laboratory testing data. We have the National Health Data Hub, which doesn't accurately have Western Australian data, doesn't have Northern Territory data. They're pretty important states, aren't they, Michael? And that doesn't have laboratory data in it either. So people do, maybe not so much in WA, but on the East Coast, people travel borders, they travel across borders. So to have a state-based only data linkage system is really not going to work. We need to have a whole of country linkage system. All the data are there. We have all these data collections, they're public records. It's actually in the public's best interest to be able to link all this information. There's a way to do it with alleviating privacy concerns, as we have done for 35 years in Western Australia. So I really do think we need to work on these systems a little bit more. That's not to say people aren't working on it, because people are, and it certainly is getting better. But we need to keep on pushing. We need to keep on pushing our politicians, our health systems to make these data readily available at a quicker pace, because it's too slow. Even in Western Australia, it takes me 3 years to get my data. That's just not good enough.
One final question from the room.
Yeah, Phil Britton, Hannah, well done. Great talk, and you're getting peppered here. I wanted to ask you about the age-specific sort of infection seasonal data that you presented, which is very interesting. And the question is, are you advocating a seasonal program for nirsevimab or vaccine, or both, or a continuous program? What do you think?
Yeah, look, I put that slide together without sort of thinking about, if I was a policy maker, what policy would I have? I think it deserves a conversation. I think it's to me, the data's pretty clear that pregnancy vaccine is great, but for summer-born babies, pregnancy vaccine may not be great. So we have a monoclonal antibody, at least in WA, we've shown it to be quite effective, Queensland as well. So maybe there is, rather than having the situation where maternal vaccine, if not then nirsevimab, maybe we should consider for some born babies nirsevimab at 2 to 3 months. Maybe that should be considered. I'm not a policy maker for my health department, I'm a researcher who's guided by data. So I'll leave that thought there.
Thank you. Can everyone join in thanking Associate Professor Hannah Moore? Fantastic talk, and did great with those questions. And I think it's a concept, that last question will be a concept we can come back to in the panel discussions.